We at Thank you, Kaya. We at Families USA are thrilled to engage in a discussion about the effective use of peer supports in behavioral health care and crisis intervention. This topic is timely as many states try to add behavioral health expertise to both 988 and mobile crises. A recent political article published today actually highlighted some of the early results of the 988 suicide prevention line launched in mid-July, and the line saw a 45% increase in calls in August of this year compared to August of 2021. So exciting advancements as it relates to the 988 line. A number of communities are trying, as I mentioned, to ensure that people are knowledgeable about behavioral health generally, either in response to a crisis, as it's preferred to law enforcement, or in some cases are part of a team along with law enforcement. The reality is that our nation has an enormous behavioral health workforce shortage. And we want to be sure that people with lived experience are part of the response teams and are looking forward to your expertise on both how to best support people with lived experience who are in these new roles and how to pursue state advocacy on this in the coming months. We are pleased to be joined by Patrick Corrigan. Patrick is a distinguished professor of psychology at the Illinois Institute of Technology and a core faculty member in the Division of Counseling and Rehabilitation Science. Currently, he is a principal investigator of the National Consortium for Stigma and Empowerment. Patrick also heads projects examining integrated care, primary and behavioral health care in a health disparities framework. Among the books he's authored, The Power of Peer Providers in Mental Health Services, we've cited Patrick's book in a recently published PCORI-funded paper entitled Peer Navigator Support for Latinx Patients with Serious Mental Illness. Dr. Paul Pfeiffer is a Susan Crumpacker Brown Research Professor of Depression and Director of the Mental Health Innovation Services and Outcomes Program with the University of Michigan Department of Psychiatry. He is also an investigator with the VA Center for Clinical Management Research at the VA Ann Arbor Healthcare System. Dr. Pfeiffer's research interests include developing and testing peer-based interventions for suicide prevention, assessing and improving the quality of depression care within the VA health system, and the implementation of evidence-based mental health treatment and collaborative care within primary care. Our third panelist is Karis Jan Myrick. Karis is Vice President of Partnerships at Inseparable, a growing coalition that fights for a future where mental health policy is no longer an afterthought, and leaders recognize that mental health care is healthcare, period. Karis currently serves on the board of and is a policy liaison for the National Association of Peer Specialists and the Board of Directors for Mental Health of America. Ms. Myrick's personal story was featured in the New York Times series, Lives Restored, which told the personal narratives of several professionals living with mental health issues. She is known for her collaborative style and innovative whole person approach to mental health care, and is a podcast host of Unapologetically, Black Unicorns, which centers on lived experience, race equity, and mental health change agents. Our final panelist is Karen Howard. Karen currently serves as the Director of Policy and Advocacy for Mental Health of America and has served 13 years, has 13 years of experience in congressional and political affairs. She also has extensive advocacy experience. Karen advises policy priorities and strategies for mental health of America on a wide range of issues, including in healthcare, education, and criminal justice. Her influence on federal and state policymakers is apparent through direct connections with legislative offices, as well as her ability to mobilize grassroots action. Her commitment to mental health advocacy stems from her personal lived experience and noticing the contrasting ease and difficulty between getting treatment in the US for a sprained ankle versus an invisible wound, such as mental health. Welcome, panelists. So, Dr. Corrigan, I will start with you. You've written about the power of peers to help people navigate the healthcare system and how peer support models should be adapted to best help people of various cultures and ethnic backgrounds. Can you tell us a little bit about that work?
Sure. I'm glad we're all here today because we all share this interest in empowering, hiring peers to advance the healthcare needs of people with serious mental illness. I look forward to Dr. Pfeiffer and Ms. Myrick's discussion on how it applies to 988. I want to step back and look more broadly. I'm a rehab and mental health counselor professor, and I think a lot of the rehab goals and the strategies to achieve them in people with serious mental illness, like getting people back to work and through school and living on their own and finding a significant other, all the supportive coaching strategies you can do that can be done by peer providers. What we particularly looked at is healthcare needs. People with serious mental illness get sick and die 20 to 30 years younger than everybody else. And perhaps one of the big reasons of that is engagement. They're not able to access or take benefit existing services. So in Chicago, if you had a respiratory problem, you have to go to the west side, this county hospital on the north side, see the podiatrist, and downtown to get your meds, and back up to the north side to see the psychiatrist. And they just need a person to navigate that process. And we think peers are excellent people to do that. Peers, as we're going to talk about, are people with lived experience. What exactly is lived experience? I think generally mental illness is aware and available to everybody. Everybody has experiences of depression and anxiety. Some of us tend to have bigger hurdles, and even more of us tend to be disabled. If any of those roles lead you to identifying with that mental illness and feeling like you need to say your story, then you fall in the category of somebody who can be a good peer. So peers are people with lived experience. They use their experience of recovery. And for us, recovery is such a complex statement, but I think it includes central issues of hope, that regardless of the challenges people have and regardless of whether they go away altogether, people should be hopeful to pursue their goals in a self-determined way. A couple other things about peers. Peers on one hand are people with lived experience of mental health, but another value is they often represent diverse, equal, and inclusive communities. So when we do a project on peers on African Americans with serious mental illness, we will hire peers who are African American. We have a project in the works in LGBTQ. We will hire peers who have serious mental illness and LGBTQ. So peers can break down the boundaries in many different ways. Finally, I hope we can discuss, there's an effort to try to certify peers, and there's a discussion about the pros and cons of that. In fact, Mental Health America has been a leader in a model of that. We are part in Illinois of a certificate for rehabilitation support counselors. And that's one that most states have going on now, which is training people with serious mental illness to carry on the kind of basic rehab strategies that will help people meet their goals.
Thank you, Patrick. So can you share what states and communities should be doing right now to ensure that peer navigators are available and trained similar to your certificate program to reach diverse populations in any given community?
Yeah, I think more and more states are realizing this is something worth pursuing. CMS has actually said that states can apply with a certificate process for peer supporters to bill Medicaid, which is essential for executive directors of agencies to hire them. They then need some sort of training like we all do. That training includes a fundamental portfolio, whether they could be health navigators or job coaches or education supporters. In addition, they need to learn how to use their disclosure, their pureness in ways to promote. And again, I think we're becoming much more nuanced about peers. The original wisdom of peers is they were people in recovery, but now they can be people in recovery speaking to specific ethnic groups or gender identity groups or sexual orientation groups. And I think about half the states in the union now have certificates in that space to train and hire peer supporters to join the workforce. In Illinois, 10 universities, included us, received ample support from the state for us to provide free tuition, stipends, internships, and training on the tests so they can enter the workforce directly. Hopefully that'll take about a year.
Thank you, Patrick. And if there are any specific resources you can recommend, please feel free to drop them into the chat, a link to those resources into the chat. I will shift now to Dr. Pfeiffer. Dr. Pfeiffer, in 2019, you were piloting a study on suicide prevention and intervention delivered by peer specialists. What was that intervention?
So we developed an intervention that builds on sort of what Dr. Corrigan was saying in terms of what peers bring inherently to a relationship in terms of being a source of hope and also kind of connection and decreasing people's sense that they're kind of going through this alone or they're the only one that's been through something like this. And we provide that peer specialist relationship, but then we also provide additional sort of guidance and content, if you will, to even further bolster a sense of hope and belongingness by working with individuals to engage in a variety of sort of conversations around, it could be setting goals, thinking through their values to build a more kind of meaningful or purposeful life. We talk about safety planning. We talk about building out a support network, relationships, those sorts of things. So it's essentially an intervention that starts on the inpatient unit for people who have been psychiatrically hospitalized for suicide risk, and then it's a 3 months of one-on-one peer support after that hospitalization, kind of during and through.
So what has happened since that intervention was implemented? What were some of the successes that you all saw?
Well, so the pilot study was successful, so that led to a larger study. And so we are actually in the tail end of that study. So we were funded through NIMH to do a larger study, and it's still ongoing. So we're recruiting out of our University of Michigan Hospital and also out of the Henry Ford Health System. And we have recruited 430 people, and we have 3 more months left. But a recruitment, and then probably about a year from now, we'll know the results of the study to see whether we were able to impact our primary outcomes around reducing suicidal thoughts and suicidal behaviors. Yeah, but so far in terms of what we've learned, it's largely replicated the pilot findings in terms of we find the intervention highly acceptable. People engage with the peers and work with them. And when we ask them after it's all, we've collected all the other measures, we ask them how it was, they by and large say that the experience was very helpful to them, and that just in kind of getting back to the basics, just that connection with someone that's had a similar experience, not the same, obviously, but having been through something that was helpful and hopeful to them.
So given that, what do we know about the help that peers can provide with suicide prevention? And what does that say about the appropriate roles in 988 and mobile crises?
Yeah, well, I think that's a big question in terms of how do we take what we've learned, which is a 3-month, intervention, and how does that apply to what might be a single brief phone call? And so for me, it's a little bit similar to what those initial meetings are like when the peer specialists on our study meet with someone on the inpatient unit, for instance. Like what happens just during that one brief encounter. And first of all, I think we can say that peers do an excellent job with that. They can do that very well. They can manage the balance of supporting people, bringing their own experiences into the conversation, but in a way that isn't overtaking the conversation, isn't taking the emphasis and the focus off the person that's seeking support in that moment. And so I think that we've actually did write a paper where we analyzed those first sessions, and that's basically what we found is that those conversations tend to go very well. And so that's kind of how I imagine it might go on a crisis line call. And just to say, we did another study where we did what's called a scoping review, where we looked at across the literature how peers have worked in suicide prevention activities. And it's often the case that on crisis lines, it's, depending how you define a peer, in some ways you could define it as another member of the community. And in that case, it's often peers that are staffing those crisis line, whether it be volunteers, short of like a paid peer specialist. So I think our work shows that this is can be a powerful way to move forward.
Thank you for sharing. That's good to know. We found your research by exploring the website of PCORI, which is the Patient-Centered Outcomes Research Institute. And that's a good website for advocates to be aware of, to find research relevant to a health intervention that they care about. But if there isn't any published research yet about a community or cultural practice that seems to be effective for improving behavioral health, is it worthwhile for advocates to reach out to researchers for help? If so, how do you suggest they do that, Dr. Pfeiffer?
Reach out to researchers for help in terms of
any community or cultural practices that seem to be effective in improving behavioral health?
Yeah, I think your mileage may vary depending on the researcher and their focus on those practices, but certainly I and others, I'm sure, are open to that and can help in the way we can. Sometimes we are limited in how much we know about what's going on in the community. If we're, in our quote unquote ivory tower, kind of digging through their research, but happy to try to be helpful always.
I think PCORI, the Patient-Centered Outcomes Research Institute, and SAMHSA, the Substance Abuse and Mental Health Services Administration, tend to be arms of the government who are particularly interested in translating research into the real world. And so sometimes you go to a PCORI website or a SAMHSA website, and they'll list the research there and what they're doing. And it's good to reach out to them through that way, because SAMHSA may have already asked that researcher to be available to the community.
Thank you, Dr. Corrigan.
And I'll just say, because I know that's sort of not necessarily a weakness, but not always my area of expertise. I collaborate, and we're all encouraged to collaborate with others, community groups and people that are kind of doing this work kind of on the ground. And so I work with a peer advocacy advocate. I work with our state's training facilitator and certification folks for peer certification. And then the peers that are in our study and performing this work have a voice and have actively participated in the development of the work that we're doing. And so if I don't know where to point folks, I will have other people I can call on.
That's good to know. All right, so we will shift to Karis Myrick. Karis, from your years of experience as a person and expertise, as a person with lived experience who has both run a peer support program and developed policy for peer services, what do you think are the most important issues for advocates and states to be paying attention to regarding the use of peers in 988 and in mobile crises?
Sure. So first, thank you for having me on this webinar today with such great colleagues. It's great to see also some of my friends again, Dr. Corrigan and Karen, hello, and meet Dr. Pfeiffer. So with all of that said, I think one of the places that I'd like to start is when the federal legislation started with 988 and looking at crisis system reform, one of the things that many of us noticed was the lack of involvement of people with lived experience and direct lived experience of mental health conditions, direct lived experience of suicide attempt survivors, suicide loss survivors, as well as those who work in the field, either as a peer support specialist, family or parent support specialist, and those who work in other systems that 988 is also hoping to help people evade, which is criminal and justice systems and homelessness, et cetera. And so a group of us actually, myself, Dr. Neb Jones, Kelly Davis, and Laura Van Tosh actually did a survey or a census of the states to see whether or not people with lived experience were involved in state planning, in any implementation, also any program development or future evaluation. And what we found, though it is very anecdotal because we didn't get a response, I won't say it's very anecdotal, it's very qualitatively important, I think is a better way to put it, because we didn't get feedback from all of the states, though the feedback we did get says, well, wait a minute, no, we're not involved and we're not happy with the fact that we're not involved. And also people who have been, had direct involvement with involuntary response systems, police and law enforcement response systems have also not been involved. So I think that's a great place to start. That doesn't even get you to what are peers doing in practice. It gets you to how can people who are going to be the end recipients of 988 services be a part of developing those services, so there'll be services that folks will engage in. So I think that's one start. The other also is the increased in use of peers on the lines directly. And again, how we want to define that peerness can be very broad. Yet I think it is very important to include peers who have had that direct lived experience of a mental health condition, navigating systems, being in suicidal crisis themselves, or recipients of suicide crisis services or mental health crisis services. I think that's critically important.
Thank you. You touched upon this, but how is the role of a peer different from that of a clinician?
Yeah, great question. I think Dr. Corrigan did a great job of kind of defining what a peer is, and that doesn't look like a clinician. And so, you know, a peer is a person who's using with intention their lived experience of not just having a mental health condition, but also navigating the various systems and supports, along with some training in order to support somebody else who's going through something similar. We don't do anything as far as we have scope of practice. So we do have practice guidelines and scope of practice. So we want to stay within all of those scopes of practice that don't look anything like a clinician. I think the biggest difference is, if I had to kind of like break it down into two, maybe three simple things, is one, the mutuality between a peer and the person they're serving. So that's the first thing, is there that, we're closer together in mutuality, hence the word peer. I mean, I know a clinician can have lived experience, but they're operating in the scope of practice of their license as a clinician. And many times that means that there's going to be a power differential between the clinician and the person they're serving. It also means that they may not be able to openly say, yeah, I have a mental health condition too. Because trust me, many people who are clinicians have mental health conditions, but they don't tell you about it. So they're operating, again, from this very medicalized clinical model. Peers are operating from the more of the lived experience, and they're able to openly disclose that they have a mental health condition or that they've navigated systems, again, with intention. It's not like they're just running around saying, hi, I'm Karis and I have schizophrenia. No, usually there's some intention behind why I'm sharing part of my lived experience journey with you, because maybe in our peer relationship, you're struggling with something that I struggled with. And many times the person feels like, nobody understands because I'm the only one who's going through this. I don't know other people are going through it. So that's the beauty in the peer relationship, is being able to say, wow, I've been through that too. I remember what that's like. Let's see how we can problem solve or work through the concern or barrier or whatever it is that you're having. So I think those are some critical differences.
Thank you. And so, given the vital role of peer navigators, what kind of supervision or really administrative supports might be most helpful to peers working in a crisis setting?
Yeah, so I do want to kind of back up to one thing that I didn't bring up, and that is sort of some of the barriers, and then kind of going into the supervision. So some of the barriers for peers working within, I'm very loath to say we should just be thinking about 988 and the crisis system, because I think part of our job is to reduce crisis as much as possible. So that, peers should be, of course, along the whole continuum, including part of the crisis system, if you will, including 988. So to understand what that means, we also have to look at wages and rates for peers, and ensuring that people have livable wages. And that sometimes can be dependent upon the rates that they are billing, if they're billing Medicaid. So that's going to be critically important. Many times peers are working in positions and they're living paycheck to paycheck, and sometimes they're not even living paycheck to paycheck. Also, there needs to be career ladders. Who wants to get in a profession and not go anywhere? Probably no one. So, what are the career ladders? I think the VA gives a great example of what career ladders look like for their peer workforce at different GS levels, and then having sub-levels for those who are doing that work. And then for supervision, many times the requirements for supervision, as stated by Medicaid, people interpret them very interestingly. So it says that it has to be a, what does it say? A qualified mental health provider. Okay, what is that? So the state defines what that is. And that doesn't mean that it couldn't be a peer provider, as long as a peer provider, a certified peer specialist, is stated as a qualified mental health provider in state regs. But a lot of times the providers, the supervisors tend to be licensed providers, and they are not familiar enough with the work to do the supervision. So they end up supervising how they understand work should be done in a clinical sense, which tends to turn out like little mini clinicians. We're not little mini clinicians. So what can help with supervisors who are providing supervision to peer supporters is first, it would be great if people thought about the role of peer specialist and training for peer specialists and qualifications for peer specialists themselves to be the supervisor. Secondarily, a lot of times it's important for, let's say that's not where you are yet, or you have to work on your regs or what have you. Then what do supervisors know about the role of a peer supporter? How do they understand the role? How do they understand the practice? And then how do they supervise to that practice? Because if we're going to achieve the outcomes that peers achieve, which Dr. Pfeiffer talked a little bit about, and there are lots of things that we do, which is increase activation. Great to have access, great to have engagement, but you really want people activated in their care and their supports. And that's what peers are expert at, and the evidence has shown that, then we need to be supervised to do how we do what we do the way we need to be doing it. So at the height of our scope of practice. So there's a document, I think we've already put it in the chat. The National Association of Peer Supporters actually has a national practice guidelines. And I think there are about 10 core values or practices in there, 10 or 12, I don't remember how many, sorry. And then also we determined that supervisors also needed to understand what were these practices, what were these practice guidelines. And so we added to that work from about 2017 back in 2019 to make it a national practice guidelines for peer supporters and also for supervisors of peers.
Thank you, Karen. Did you have something additional to add?
Yeah, I was going to say that the other thing that that's useful for and helpful for is job descriptions. If you don't have a good job description to start off with, that is really not going to be super helpful. So not only for the supervisors, but for our HR folks, how do we create job descriptions that, again, help people operate within their scope of practice to do the work that a peer does, whether it be on a crisis line, whether it be navigating systems, whether it be on mobile crisis teams. And also recognizing that peers do have values around voluntary and being helping people voluntarily. So I have seen instances where peers are written in to be required to work with people in involuntary settings. And what that means is a person can be in an involuntary situation, and you can't force that person to work with the peer. The person must say, yes, I want to work with a peer. So we can work with people who are in involuntary settings, but we cannot be a part of an involuntary plan without the consent of the person who is being served. So I think that's another important thing to line up. And lastly, I think we need to think about the different funding mechanisms for the way that peers are going to be offering services. Sometimes Medicaid billing does not work as well with our values and practices as it does if we were kind of maybe had grant funding or philanthropy funding, possibly block grant funding. So there are lots of different ways to think about funding peer support. We tend to look at Medicaid because it feels to be the most sustainable. And I think that's why people get really interested in funding peers through Medicaid because of the sustainability. But there are many, many models that we can use and see peers working within systems, Medicaid reimbursable, also working in peer-run organizations that are funded by philanthropy.
Thank you. And are there any payment structures that are most helpful for peer specialists, given that there are numerous payment mechanisms?
So I think they're all helpful. What I like to think about is as a person is entering into this particular profession, where do they feel comfortable? So, if a person doesn't feel comfortable billing and having to quote unquote write notes on somebody, let's just say that's what you have to do if you're billing Medicaid, then they may be more comfortable working as a peer supporter in another part of the kind of service and system array. It could be working with a CBO, a community-based organization, peer-run organization. It may be working on a crisis line or a warm line, which is sort of a pre-crisis sort of thing, or text line. So I think what leaders can think about, especially from a policy perspective, or what are all the different ways in which peer support can be funded that maximize and align with the practice of that particular profession of peer profession, and to utilize all of those, and to, if they can, braid, if it's possible, to braid funding too.
Exactly. Thank you. So Karen, I will shift to you. We've heard some anger and disappointment that callers to 988 may still end up getting a response from law enforcement instead of a response from a behavioral health worker. Why is that? And is that the case everywhere?
Hi, Stacy and panelists. It's really an honor to be here with you today. And I appreciate the question about why people receive a law enforcement response instead of a behavioral health response, which is very common. While many jurisdictions have mental health services, there really is a dearth, and I'm sure you all have discussed the workforce shortages and some of the other issues, but police are often dispatched because they have been well funded historically. They have a quicker response time than maybe a mobile crisis unit or other service that might actually be more healing. And unfortunately, states have really not invested in kind of the infrastructure and systems that is needed to really eliminate police altogether from responding to people in crisis. When a law enforcement response is dispatched, typically people with untreated mental health conditions are 16 times more likely to be traumatized by police or killed even by police. So really that's a last resort, but we haven't really seen the appetite for states to direct funding, resources, and planning and strategy decisions towards, okay, well, how can we get a behavioral health response? We did see 4 states, Colorado, Washington, Virginia, and one other one, pass legislation to fund 988 with user fees on telephone bills. But that's really the ideal way to collect some sustainable funding in the same way that is already done for 911, but for specifically people in mental health crisis or in having thoughts of self-harm or suicide. So it is often that police are dispatched and communities around the country do it. But even police officers will tell you that they don't want to be taking those calls and that there should be an alternative. So working with some police stations have been working with peer support or peer-run organizations to divert those calls. Some have not been able to do so, or they're doing a co-responder response where they're going out to meet a person in crisis along with a mental health professional or paraprofessional, such as a peer. But there really, I think, needs to be some additional investment into the mental health services, including workforce, to ensure that police are completely taken out of the equation.
So given that, how should advocates be asking their officials to solve the funding shortage and other problems?
Yeah, great. Thank you for the question. There is a 911, 988 working group that has been created in the states. So each state has a 911, 988 working group to help inform and share information and also kind of learn from 911 and how that system was created, but improve it and do things better and more targeted for people with mental health conditions. So one way is for individuals or organizations to join those working groups. There's also a national campaign, the Reimagine Crisis, that National Alliance on Mental Illness has created. The Reimagine Crisis campaign has like an action alert to send letters to the state and local representatives asking for funding through user fees. And really, some states have done, like I said, have done the work to pass user fees on telephone bills, but really that's the main way that we're asking folks to fund. So building relationship with state legislators and encouraging them to think about why it's important to have sustainable long-term funding, you know, building off what Karis mentioned about the ability to have, you know, long-term sustainable funding for peer support, just as we need for crisis services or crisis counselors and those who may be paid or unpaid volunteering their time. If, as we saw with the COVID public health emergency, when the funding dries up, people end up just really suffering and going without, versus having something that's ongoing and sustainable. And then finally, working with governor's offices and behavioral health agency leads, including Medicaid directors, is really important. And of course, as you know, politics and elections take place, you have to rebuild those relationships every 4 years or so, however often. But if there is a ongoing kind of campaign and pressure to build relationship and influence the actions of administrative leads and staff, you know, I think that education and that advocacy goes a really long way into more sustainable systems.
Thank you for those suggestions, Karen. What are MHA's top asks of state officials right now?
Yeah, so we are focused in particular on getting the 988 user fees passed. We're encouraging our affiliates on that front when it comes to crisis services and ensuring that there's just, you know, in 10 years, we're not at the same place we are now with studies or completely ignoring what needs to happen. We're also asking that peers and people with lived experience are at the helm of decision-making, so that when states come together or they have a planning committee or they pass bills, they have a person with lived experience or a group of people with lived experience that are informing implementation on the administrative side. Often what we know is that when people with lived experience are left out of decisions and planning, the systems don't really work for them and aren't able to learn to improve user satisfaction. And of course, if a person is not served well or not satisfied by their service, there should be some measures in place to, you know, ensure that that voice is incorporated into the systems. And, you know, some primary care is doing this already. There's other, you know, types of fields that are doing this, but in the mental health space, we tend to ignore the voices of people with lived experience. So that's our other top ask.
Thank you, Karen. How can advocates who work on other aspects of health policy best connect with you and stay informed?
Sure. So Mental Health America has been putting out action alerts through our advocacy network that allows individuals to kind of weigh in and send letters to their representatives, and having that kind of grassroots groundswell is really important. So I encourage people to join the advocacy network. You can also get in touch with me directly, C. Howard at mhanational.org. And there's a couple of different groups that we're a part of that we're always seeking, you know, information from others about to help with the forward movement of the coalition. So if anyone wants to join some of those coalitions with us or inform us for that work, we're happy to work together.
Thank you, Karen. I have two questions for all of the panelists. We've been talking about mental health crisis broadly, what about substance use disorders? Are there differences advocates should be aware of about how peers can help people with substance use disorders? And what state policies should we be advocating about as it relates to substance use disorder?
Generally, I would encourage us to put the DSM away. The idea that, you know, you're in this group, or you're in this group, or you're in this group, and therefore I should react this way, this way, or this way. I think the common thing in 988 is people are struggling with some version of suicide. And so we need to listen to them. We also need to listen to them whether substances that are making it worse, or psychotic symptoms, or depression, or fighting with their spouse. And so I think we always got to be mindful and careful of not categorizing people and then talking to them in their categories.
Yeah, I would
Wonderful advice.
I second that. There is some within the state. It seems like there is some division. There's recovery coaches it's sort of an analogous type of position to a peer support specialist that's more focused on your recovery narratives around substance use and addiction. And so there is some kind of division, if you will, there, but at least how we approach it with suicide risk, it doesn't matter whether someone has a substance use problem, and a lot of our peer specialists also have that in their history. So we sort of don't make that division ourselves.
I don't really have much more to add. Yeah, couldn't agree more.
I do think that stresses the issue here of identity and not diagnosis. It's what people identify with. And, you know, some people really identify with the substance use disorder community, and other people with mental health, and with mental health, within mental health, some with this disorder or that disorder. I think we need to listen to their identity. And then with identity, again, is this whole diversity issue and systematic disadvantage issue. So we've done work with returning citizens, with ex-offenders, and they're supremely wonderful peers when they're talking to other people, because they've been there. They know what it means to come out of jail.
Exactly.
I just saw a question from Cheryl about, I think about covering peer support through private insurance. So I just want to mention that the No Surprises Act that passed Congress last December was supposed to ensure that people did not get any surprise bills after being released from the hospital. And in the August FAQ that the Department of Labor and Treasury and Health and Human Services put out, they clarify in questions number 10 and 11 that crisis services, crisis stabilization is, must be covered by insurers and can't be excluded from this idea that a consumer should not receive a surprise bill. So that was a win for, anyone who has experienced crisis, that they should not be, also dealing with financial burden on top of the crisis. And then there's also, we're expecting a regulation from the Department of Labor, hopefully before the end of the year. They've said that they were going to do it. They pushed it month by month, saying that it's coming, but hopefully that will really codify parity, which says that benefits or services for people with mental health conditions should not be provided at any additional cost or with additional restrictions or limitations than any other medical or surgical benefits. And so that should also include crisis services. And then also a third thing is MHA is pushing for Medicare Advantage, which are commercial plans paid commercial plans people can sign up for that are Medicare benefits, but they're actually kind of capitated payments. So a commercial insurer receives one big check from Medicare for a person's care, regardless of how, like what exact services are given or things like that. So anyway, in that kind of, it's like a public-private partnership kind of, we're advocating for ensuring that peer support can be covered as a regular traditional benefit rather than just a supplemental or optional benefit. So there is some work being done to broaden coverage of peer support and to do so in a way that is not limiting, but because many providers are unaware of how to actually work with peers and incorporate peer support into their practice. So ensuring that there's some provider education of clinicians, as well as the, insurers and health plans, benefit structure set up to really honor the work of peers. So I wanted to touch on that before we got off.
Thank you, Karen. On that note, I have one last question. How, considering the behavioral health shortages, how can peer specialists be a part of a behavioral health workforce pipeline? Thinking of the career ladder and from moving from a peer navigator to part of a team, a behavioral health team, clinical team.
Well, I mean, I think I would start by saying, that we can think of peers operating in all sorts of different ways, especially to meet people where they are. Many times, we know that people, may not seek out conventional services at, for example, a brick and mortar mental health treatment center. We know that. So, having peers in the community doing outreach and engagement, also having peer-run programs, peer respites, which I should add as a part of the array of services that can be funded in lots of different ways. You can look at Oregon, for example, just passed some legislation for peer respite and how to fund that peer respite. So I think there are lots of different ways in which peers can start that involvement. I think our job has to be not limiting our vision and our, I'm going to say not limiting our vision to what a person with lived experience in a peer role or lived experience role can do. And I'll just be very frank, when I first started in this work, I already had 2 master's degrees and everybody said, oh, but all you can do is be a peer specialist. And I kept saying, no, what I like to do is run programs. What I like to do is, help people be better at work. My background is in IO psychology, and that's what I do. So, but it was like this very sort of limiting view, very stigmatizing view of what peers can or cannot do. So I think we need to really think outside of the box of peers working all the way from providing direct services, supervising, running programs, doing policy work, doing, working at the state level. We have, state legislators who identify as having lived experience. Do you know who your state legislators are who do that? It'd be cool to know, because those are folks who are actually, in Washington State, for example, helping to move very sound mental health policy and legislation. So I think we need to be intentional about thinking about the various roles that peers can play, and then creating those opportunities and sustainability for those opportunities as well.
Thank you, Karis. And thank you to all of our panelists. We will now transition to any questions. There have been a number of questions that were added to the chat. One question is related to job descriptions and if there are any suggestions for promoting job descriptions effectively and making positions attractive and rewarding for potential employees.
I don't know if anybody else wants to answer this, but I know on the National Association of Peer Supporters website, if you, and again, we put the link in if you want to put it in again for the peer support and supervisor guidelines, that's one place to start. Also on the Substance Abuse and Mental Health Services Administration website, you'll have to Google a bit for it. When brass tacks are bringing recovery supports to scale, technical assistance center strategy, that's why we call it brass tacks. It is archived. There's a lot of information there around peer support work, peer support workforce, job descriptions, supervisory checklists, all sorts of things. So I think if you go to the SAMHSA site and Google peer support services resources, something like that, you'll find all of that information there as well.
Thank you, Karis. There's another question about advocacy for increased reimbursement rates / PRSS salaries and a managed care system and what that advocacy looks like. I believe this is Susan Kennard. The state doesn't set rates or salaries, and the decisions are made by MCOs and providers. So any recommendations on advocacy as it relates to increased reimbursement rates?
I could keep going.
Okay.
I mean, these are areas where I'm just like all up in it, right? And I think, Karen, you may have something here too. I'm not quite sure, but I think there are a couple of things. One is we've had a wage study that was done in 2017 with the help of the CBHL, the College for Behavioral Health Leadership, with Alan Daniels and a number of people. I think that's a nice place to start. It's old, we need a new one, a new wage study. I know rates and wages are different, but we sometimes have to start with wages to figure out our back into rates. The other thing is, I think it is important for us to understand what are the rates across the country. And there is a study through Open Minds. It's not open access, sadly, but if people have paid the gazillion of dollars to get access to Open Minds, you could get the rate study that CMS, because you have to go to each state. It's not easily available, right? So we actually need that, I think, to be open source so that people can understand, but where do we need to be? What's the highest? What's the lowest? What are they billing on? That's for looking at that. So we need a new wage study and we need a new rate study. Then I think we need to encourage CMS to look at what kind of guidance can they provide to the states. So even though states may not be setting, some states may not be setting the actual rate, having guidance from CMS is a very strong push, if you will. There's no shall in there, but there's a strong push when they hear that CMS says, hey, these rates do not support a living wage for peers in your state, community, whatever. So these are things that you need to be thinking about at the state level, at the MCO level to set those rates. So I think if we can get CMS to kind of put some guidance out to states, Karis Myrick thinks that that would be super helpful.
Thank you, Karis.
Yeah, I agree and have worked with Karis on trying to get the PEERS Act passed, because if peers are set up to be reimbursed by Medicare, that would set a national standard for payment of peers that then states could follow. Otherwise, as she stated, you must go state by state and do advocacy with each Medicaid director. And that is going to be more of a difficult task. And many states don't even have peers in statute at all, by definition. So you first have to educate around what a peer support specialist is, or a peer recovery specialist is, and then about the work that they're doing and why it should be valued higher than it currently is to afford people a quality of life.
Thank you, Karen. Well, it's 4 p.m. and I'd like to respect everyone's time. Thank you all. Thank you, participants and panelists, for joining us this afternoon. And we will share future events with you all via email, hoping to continue this conversation. There's a lot more to explore. Thank you and have a great
Thank you
afternoon.
so much.
Thank you.
Thanks.